Oh, can you see this? Everything good again?
Looks great.
Okay, all right. So objective number 1, trauma-informed care. So there's the 4 kind of R's they talk about for trauma-informed care. And really it's I think of it as universal precautions, the same way we do with bloodborne precautions, universal precautions for trauma, assuming that everyone has probably suffered, or many people have suffered from trauma, and that it's going to affect the way they receive medical care. So realizing the impact that it's going to affect the way that you can take care of people, recognizing signs and symptoms of trauma, how we respond to that, both as individuals and as an institution. And then really the main goal, like I mentioned, resisting re-traumatization. So all the things that we do to people, for people, but to people in the hospital can really bring back a lot of memories and re-traumatize people who have that history. So we're going to talk not just about trauma in general, but specifically about torture, since this is a day of discussing immigrant and refugee health. But torture is defined by the World Medical Association Declaration of Tokyo. It's the deliberate, systematic, or wanton infliction of physical or mental suffering by one or more persons acting alone or on the orders of any authority to force another person to yield information, to make a confession, or for any other reason. So the patients we see here in clinic, the patients you see inpatient have suffered likely a variety of harm. So from blunt trauma, sharp trauma, I've listed some of the things below. These include female genital cutting, which also we see a lot of. And then, not to downplay, but mental and psychological torture being oftentimes just as much damaging long-term as physical torture, if not more. So I'm going to play, this is a video clip of one of our patients in IMC. And like I mentioned it before, these videos are patients who have agreed to share their story. They wanted to educate health professionals. And so this is not, just for background, something that would necessarily come up in just a regular clinic visit. Sometimes asking details of someone's trauma can re-traumatize them. And so this is not just a regular clinical interview, for some background. If the sound does not go through, there are subtitles from the interpretation that hopefully will. Oh boy. Okay, restart the program. We're having a variety of technical difficulties today. Let me see if we can get this going.
I also have the videos, Nicole.
Do you? Okay. Let me try one more time and then see if it's not. I put them in that drive. But,
yep.
Okay. Okay. Shri, are you able to play them from your side? I don't know what's going on.
Yeah,
here.
happy to.
Okay, thanks.
If you stop your screen sharing, I'll pull it up.
Yeah. Okay, got it. Hold on. Sorry, now my Zoom is. Okay. Sorry, it's not letting me stop my screen share. Nikki, are you able to do that from your side? Oh, there we go. Got it. Sorry.
I did it. Sorry.
Okay.
All right. Let's see. Can you see this?
Looks good.
When they beat you, did they knock you out? Did they hit you in the head and knock you unconscious? They beat you the rear of the gun, they will hit you on your head. Yes, I collapsed, yes. Do you know if you were unconscious for a long period of time? Because it didn't happen. Yeah. What about broken bones in your head, your jaw, your body? Did they break you? Well, oh, I'm so sorry. What about burning you or shocking you or boiling water? Did they do any of that to you? No, they did not. Did they cut you at all or no? What about now? Do you continue to have headaches or memory problems or hearing problems? Yes, I have headaches or jaw pain.
Okay, Shri, we can stop at that point. Thank you. Okay, so let me go back to my share screen. I'm going to try it from the non-presenter view and see if it doesn't crash this time. Okay, so just talking about torture prevalence, why we're talking about this is that if you'd work with any refugees or immigrants, chances are you are working with torture survivors because the prevalence is so high. It's known to be, torture is known to be systematically practiced in nearly half of the world's nations. That's just where it's known. And of course, numbers are hard to come by in terms of prevalence due to a variety of factors, but at least, back in 2015, it was thought that there were 1.3 million torture surviving refugees living in the US. And so that's quite a bit greater even than the number of people living with Parkinson's in the US, just for comparison. And then, of course, like I mentioned, data is hard to come by for prevalence, but some smaller studies looking at prevalence of torture by people group. I put some of the most common groups that we'll see here at Harborview, but up to 55% of Oromo-speaking refugees report a history of torture, 36% of Somali, over half of Cambodian refugees, and then you can see for Iraqi and Karen speaking refugees as well. So just really, really high numbers. And these are the ones who report it. So chances are they're actually even higher. Okay, so the next section we'll talk about is when to suspect a history of torture. And of course, the high-risk populations, like we mentioned, refugees and asylum seekers, but other places that you're going to run into, high numbers are veterans, so VA hospital, people who are incarcerated, so also a lot of the people that you'll see at Harborview, those who are disabled, and then the LGBTQ population as well. It's also good to have your radar up when you're seeing people who have psychiatric symptoms of trauma, so people who are suffering from depression, PTSD, anxiety. And another red flag where you might start to wonder, about someone's trauma history is people with chronic pain, and something that I'm going to term here kind of non-anatomic pain. So pain that may not fit with your, our understanding of dermatomes and nerve roots and, the biomedical kind of teaching that we have. Sometimes people report physical connections that were not created, that don't necessarily make sense from that perspective, but they were created by specific torture experiences. So like this man, we'll get back to our case, who reports pain that worsens when he's hungry or pain that worsens when he doesn't sleep. Some things like that may not make sense without knowing someone's history. Another study reported up to 78% of people, or 78% of people with a torture history reporting chronic pain in multiple areas of the body, with the most common being headaches and back pain. And then other ways that a torture or trauma history may come up in clinical care is the issue of non-adherence. So this is just one patient, one torture surviving refugee from Uganda, who said, when I came to the US in the early 1980s, my nightmares got worse. The hospital setting brought back bad memories, and it was difficult to tell people what had really gone wrong with me. The doctors never asked questions about the source of my nightmares, but gave me medication anyway. Eventually, I did not take the medications prescribed. So we're going to do one more video, or two more, actually. This is a patient that we base the case off of. Again, he wanted to share his story and went into a good amount of detail with his doctor, Dr. Jackson, who he'd known for many, many years. And he, so this again is more detail than would normally just come up in a usual clinic visit. Let's see what we could do.
We're not getting sound, but I think we can read what he's saying.
Okay. Okay. I think the video might have stopped too. Let me
Yeah, it
see.
was frozen.
Okay, let me see if we can. Okay, I'm sorry. I'm not sure what's going on with the videos today, but this gentleman from Vietnam talked about his time when he was in prison. So he was trying to escape and was and when when he was caught, he tried to kill himself but was unable to do that, and so was put in arrested and put in confinement in a small cell, a cell that was too small for him to stand up fully, too small to lie down fully. And he was kept there for years, and actually was in solitary confinement for over a decade before he was released. And so he talks about some of his experiences. Like his legs were shackled, and to torture him, to keep him up at night, the guards would pull on the chains on his legs to keep him awake and keep him from falling asleep. And so this was one of those cases, like I mentioned before, where, you know, knowing his history, his leg pain that worsens when he can't sleep or when he's hungry makes a lot more sense. And just for background, this is a patient who he had been at Harborview for a long time and seen many subspecialists. I think he also saw Dr. Kopis, and for many years before any of this history came out. Had a lot of workup for his chronic pain, but it was only many years later. I think Dr. Jackson had been his doctor for probably a couple decades before he learned about this history. So we're going to focus the rest of the time on the fourth objective, which is preventing re-traumatization, what we really want to do. There's not, you know, we can't change the past and the things that patients have experienced, but we do have a lot of power in our hands to be able to either unintentionally re-traumatize them when they come to the hospital, or to do the opposite and to try to prevent that from happening. So the hospital setting is really hard for people, as you can imagine, even for English-speaking people with high health literacy. It can be really hard to come to the hospital and be out of control. There's a huge power differential between the medical team and yourself. And, you know, for people who suffered torture in other countries, it can feel similar. The procedures that are done to people, administration of drugs, and, you know, with the language barriers, maybe not completely understanding what's going on. And then in some countries, physicians are the ones who are supervising or even performing the torture. And so to have that coming into the hospital for people can be very, very difficult. And when people come to the hospital, there's a variety of things that we do that we may take for granted, that just seem very mundane and everyday, but can be very traumatizing for people. So I put some pictures just juxtaposed by each other. You know, a lot of people have suffered from positional torture or held in confined spaces for lengthy amounts of time, forced to hold certain postures. And then we do things in the hospital, restraints, MRI scanners, all sorts of things that restrict their movement. We also do a lot of things for people who've had electrical torture or been shocked, which unfortunately is fairly common. In the hospital, if you roll into the ER for almost any complaint in your upper body, you'll probably get an EKG. And if in the case of emergency, there's probably not going to be an interpreter explaining everything that's going on in the moment. The bottom is EMGs. And then another thing that, you know, I really didn't think about this, how traumatizing it would be for people until a patient brought this up, but dieting or being made NPO for people who have faced starvation can be very difficult. And this is something we do all the time in the hospital, right? We make people NPO past midnight, just in case we're going to do the procedure in the morning and then it gets delayed, then they're NPO again, then they're NPO again. And, you know, I had a patient, this came up, a Cambodian lady who with diabetes, and this is just on the outpatient side, who said, you know, when I talked to her about diabetes and talked about dieting and losing a little bit of weight, it was really difficult for her because it reminded her of the time where she suffered under the Khmer Rouge and actually lost some of her children to starvation. And that's not to say that we can't do these things to counsel on diet or counsel on, or, you know, make people NPO, but but knowing that it may re-traumatize people and then letting people know why it's important or approaching it a little bit differently can prevent some of the damage that I unintentionally done. One last video. I would love for sound to go through on this one. Shri, are you able to? Okay, let me stop mine. And this is another patient. So what I love about this video, this is another of Dr. Jackson's patients.
First relocated here.
Oh, sorry. One sec. Let me just give some background. So this is a Cambodian patient. And so his torture under the Khmer Rouge happened decades ago. He'd been in the US for a long time. But what he's going to talk about is how some of the memories, it didn't come back until later. So it wasn't that that once he got here and settled and everything got better, it was when he started to get sick and when his kidneys started to fail, that's when all the memories started coming back. And so when we see people in the hospital who, when we talk about dialysis, it's, not that it's not a big deal, but we have plenty of people who do just fine and live on dialysis for many years and do great. But for this patient, this was basically feeling like a death sentence for him. So, okay, go ahead, Shri. Thanks. I'll be there in just a minute.
When you first relocated here, did you have trouble with depression, and did you have trouble with bad memories at that time? Have trouble with sleep?
Me and
And then eventually, it faded into the past, or did it always stay with you?
the whole sắp này là chủ cáo nhom mình về nhom chữ nhom ở số luôn đấy nhom thấy tôi sắp từ từ cả tôi đi bài ở miền bài từ chủ cáo tôi sắp thì đánh chuẩn bị vào đầu tiên đây
So when you started, let me just rephrase that again, because I think that's important, that when you were starting to get sick with the kidney failure or with diabetes, which was it that you began to start remembering the past and it came up for you?
Yeah, tôi kỳ hào thà liên chia máu nhưng cái tập phải cái trả đi cho xong
Đang bị cái bạc thà rong nông nông khâu chào trời liên chia
năng này
những cái rồi
nhưng đây là ba này cần
Did it affect you in other ways? Did you feel more sad, less energy, anything else that could affect your relationship?
từng on
nhưng đào về nó nhưng chắc tôi đi nó slap ở đưa ra con tôi đi này chọc chỉ bật nhưng vẫn có.
How was that like the Khmer Rouge times? How is that similar?
Về nó also come to clean up the airport. Có sự come ra dùng slap đấy. Ngày nào cũng dùng slap đấy. Hay ở đâu ní về con tôi đi nó còn mà toàn bao tôi đi chiếm đó. Cho nênเคยแต่มันจะแบบประบายcho hào mà hay xong doctor tôi đi sọc mai chú bao phone mà đó doctor ta phải tầm đo lên tới ấy mau bên bàn rồi hay nói che tập hay đi ra đi dùng là
Thanks, Shri. We can stop there. Okay, let me go back to mine. Okay, thanks. So I think it's just a great illustration of that. We talk to people all the time in the hospital about things, and people can refuse for a variety of reasons. People refusing to go to a nursing home, people refusing certain tests. People not wanting to follow up with specialists, and sometimes there's deeper meanings or deeper reasons for why people don't want to do the things that we're recommending. And it's helpful if we know that and approach that with that understanding that there may be trauma behind that. All right, so oops, now our screen's being funny. So if and when to ask. So like I mentioned, these patients agreed to share their stories for educational purposes. This isn't something that we advocate for universal screening every single person on an intake when they come in, but really it's helpful to watch for patient cues. Sometimes people want to talk about their past and their trauma, and sometimes they're very guarded and don't want to. Sometimes it comes up just during social history, asking, how did you end up here in Seattle? What was your journey from where you were born to how you got here? It comes out sometimes in forms, so patients asking for citizenship exemption forms or disability forms. And then, like we mentioned before, just assuming that trauma has occurred, even if we don't ask, approaching them with the knowledge that that it's possible and it may affect the way that we provide care. So, so specifics, how do we actually ask this when we decide that this is something that, you know, a patient is giving us clues that they may have something that they want us to know about. Some of the things that I say are, you know, that many people have experienced trauma that affects the way they want to receive care, or in the case of our clinic where everyone is born in a different country, you know, many others from your country have experienced XYZ. Has any of that happened to you? And then, like I mentioned, social history. Where were you born and what made you leave and how did you get here? What was your journey like? And that gives people the permission to share as much or as little as they are able or wanting to at that moment. So other things we can do to prevent re-traumatization, just all the usual things about giving control back. So making sure patients know that this is a confidential setting. Sometimes people, if they're from a country where state hospital, you know, can't necessarily be trusted, that they may not have that same sense of safety with doctors here. Allowing them, can go either way. Sometimes companions can be helpful to a visit. Sometimes they are detrimental. Offering chaperones if that's something that the patient wants. And then preparation. This goes back toward the earlier discussion that Shri and Alex gave about interpretation and the importance of good interpretation, preparing people for what procedures are going to be like or what happens in the hospital, what the process is like here, not just in a foreign country for them, but a foreign setting, the medical setting sometimes. And then asking permission before touching the patient, before asking questions, things like that, giving them permission not to answer if things make them uncomfortable. And then the last thing I want to leave with just is that it can be helpful for people if you know that they have a torture or trauma history, just educating them on prognosis. We talk about the triple trauma paradigm, like the multiple traumas that happen with displacement and resettlement. So there's the first trauma of the whatever happens that makes somebody leave their country, whether it's war or persecution, political unrest. So there's that initial trauma, and then the trauma of flight and you know, escaping where they're coming from. Lots of uncertainty, sometimes separation from loved ones, physical and mental suffering. And then the third trauma is what a lot of people don't anticipate, which is the trauma of resettlement. So coming to the US, when a lot of people expect all of their problems now should be better now that they finally made it where they've been trying to get to safety. But then all of the things that happen here are oftentimes just as traumatic as what made them leave in the first place. So so torture-related symptoms, like our patient with renal failure, it's like a chronic disease. There's times where things may be worse and come up, and times where they may be better and not be in the forefront of your mind. So sometimes it's helpful to let patients know that. So those were our objectives. I'm going to stop here for questions, comments. I'd love to hear other experiences people had or have had with dealing with this population, or other insight you have. I'll stop my share.
Yeah, thanks, Nicole. It was really powerful, especially to hear those patient stories. A lot of those images that you shared reminded me of, you know, specific patient encounters during residency. I wonder if anyone else, if those brought memories for anyone else.
I do not take care of a super high proportion of refugee or immigrants at Roosevelt Women's Clinic, but we have lots of patients that have other types of trauma as well.
Yeah.
And you know, the universal precautions idea, of course, is super important, but I've been really reflecting on patients that I often am maybe earlier in my training was like, why am I not able to connect, or like what is going on here? And at now 4 years into knowing them, that like I know now that they have had a traumatic experience that directly plays into what they are feeling and experiencing, and that there's often something deeper, and that is our entire medical system inherently traumatic for patients. These people that are admitted frequently or have frequent healthcare contact, is that itself a form of trauma? Like, I think it probably is, but us both as like perpetrators of trauma and people that are trying to heal others from trauma, and thinking about that.
You know, I thought about this a lot as well when I was working at the Pioneer Square Clinic for many years, you know, thinking about adverse childhood experiences as being risk factors for later struggles. And many of the patients I cared for there had really horrific or challenging childhood experiences that would fall under, you know, a definition of torture or trauma. Um, and that what that did then to their ability to cope later with medical illness or with navigating complexity or with achieving sobriety was, you know, it is this trauma informed care, this thoughtfulness about avoiding re-traumatization is so true in many populations.
All right. Well, feel free to reach out if you have any other questions or thoughts. I'm going to include Nicole's email in the last slide of this morning. But thank you so much for the lovely presentation.